Hi, colleagues. My name is Yahya Ithawi, and today I will be talking about something emerging, something that we are not used to, something that will be very scarce and little information, something that we are not sure of, but I depend on many references to make this talk, although personally I don't have experience because I was not exposed to any case like that, but I use my other websites and other other countries' information, and also I use my experience with the drop and droplets infection and also airborne infection, and I try to address all the issues that we exposed when we deal with patients of confirmed or suspected COVID-19 mothers. So the objective of this talk, we will talk about what we will do in the resus room, what we will do if the baby is stable, what we do if the baby is unstable, what we do if the mother is stable or unstable, if we need an extra care, how we admit to an ICU, how we do the transport, when and how test babies, whether for COVID or other tests and care needed. What about breastfeeding? Do we do screening? How we do if we have increasing number of an ICU? What about the parents if they are infected or they are not infected just for visiting of this current situations? Do allow other visitors to come in? How we discharge and how we fill up? What about staff? And what if we need other services such as imaging or any other subspecialties? So as I said, for the resuscitation, these guidelines are the best available evidence, although the current evidence are very limited. But we can say that a designated senior neonatologist should attend these deliveries and not leaving them to a junior staff. So any mother who suspected or confirmed COVID-19 and in labor should be attended by a assigned senior neonatologist. The most important is personal protection equipment should be on in an adjacent room, in nearby room, and the team member should stay and not attending delivery until, if they are needed, they go inside the delivery room to care the baby. If we anticipate that the baby needs resuscitation or respiratory support, like a premature baby or a difficult labor or any other high-risk deliveries, there should be a senior skilled neonatal team to take care of respiratory support. Of course, prior entering the room, again, they should put on their personal protection equipment. However, the other standard of care for resuscitating and stabilizing a newborn baby should be same as the standard of care. And when we move the baby from one room to another, or from one facility to another, or from a resus to an ICU, should be inside a closed neonatal incubator. All the procedures and investigations should be carried out in the same isolated room. It's better to do the resuscitation in an isolated room other than the maternal room, if possible. And to limit the number of staff. So don't bring more than 3 personnel in that resuscitation room. And avoid to do the resuscitation with the mother because delivery are, lots of secretions and contaminated biological materials. So to avoid that, it's better to do the resuscitation in another room. Now, the most important question, should we give steroid, antenatal steroid, dexamethasone or betamethasone, to improve lung maturation for a baby suspected to be born prematurely? The answer is yes, but there is no evidence. However, it seems that giving steroid to the mother will not harm the baby or the mother if she is suspected or confirmed COVID-19 infection. Again, magnesium sulfate that is used for neuroprotection for babies less than should be given also. There is no evidence that it may cause harm. However, this might change. Incubators, ventilators, intubation tools, IV set, and any other devices should be cleaned in that single room as the policy of the local infection control group or committee. Considered and take care during intubation because suctioning And suctioning and also applying non-invasive pressure can cause loss of drop and droplets. So we should be very careful when we intubate and do suction. No suction or intubation should be done without personal protection, especially you have to put goggles or cover the eyes, protect your eyes, put gloves and mask. Now, if the baby born in good condition, then and there is no immediate medical care is needed, then the baby should be remain with his mother in the mother designated room. And this baby, if stay well, should not be tested. And the test is only happen when we do or if the baby is unwell or the baby is sick. Now, if the baby is sick, need testing, need admission. If the baby is not sick, no need testing, no need admission. Now, with that, then we have to talk about, the mother. If the mother is unwell and the baby is well, then this baby should be, guaranteed and kept with a caregiver or relative of the mother in a special designated room separated from the mother or at home. The baby, if the mother is well and the baby is unwell and admitted, the mother should not be allowed to see the baby until she is recovered. We should encourage, in well baby, should encourage early discharge, however, taking the standard of care before discharge as best. Again, all the care should be carried out with personal protection equipment. If an extra care is needed, it's vital to contact and talk with a senior person. Extra things maybe in the ward or with the mother, so for example, need intravenous antibiotics or need phototherapy or need special investigation for them. Should we keep the mother and do that, or should we admit? Now, the senior person should assess and see what is a safe practice that can be done, whether beside the mother or inside the mother room or outside, should we admit or not. However, the general principle is to avoid admission. And the general principle is to be safe. Babies requiring to be admission should be assessed prior admission in a designated labor room or ward, and then the assessment should be by a senior person who is skilled to do the assessment, again putting the personal protection equipment. Before admission, personal protection equipment is mandatory. Always keep the baby inside the incubator, even if the baby inside the single room, if the baby with or without respiratory support, if the baby with or without central line. No open coat management of COVID-19 suspected or confirmed mother until baby is test negative. So try to avoid open bed management. Clinical investigations other than testing the baby for COVID should be minimized. However, should not compromise the standard of care. Therefore, a senior person consult is important in this. So we can minimize the need for investigation, and we can prioritize these investigations. And so the general principle is to avoid unnecessary investigation. From that point of care testing or point of care procedure is important. Again, I want to stress that intubation, suction is very dangerous. No suction or intubation should be done without personal protection equipment, especially goggles and gloves and mask. This should be applied even in emergency situation. From that point, using video laryngoscope intubation, if possible, is advisable, because with using this tool, you have to be a little bit away from the intubation, and then will be away from contaminating yourself with the secretions or droplets. The intubation should be done by a senior person. and should have the competency to do it, and therefore during the procedure he or she can concentrate on her personal protection during the procedures, because if you're not skilled, you start to think of a procedure and sometimes you might forget to take the necessary precaution to protect yourself and protect your colleague. It's vital to remember that the non-invasive respiratory support, such as CPAP, causes significant aerosolizations and must be considered very high risk of contamination. Treat the baby with respiratory illness in the same way of other respiratory diseases in neonatal period. However, because the evidence is lacking, I would say try to intubate earlier than usual. Again, whether it's invasive or non-invasive, should be inside incubator. All the equipment coming out of the isolation room should be sterilized and should be sterilized in a separate room or inside the same room. It's vital to keep a logbook or registry of the staff coming in and coming out, their name, their designation, and the timing, and how long they were inside the isolation room of that baby. During transport, try your best not to transport. Having COVID-19 suspected or confirmed mother is not an indication for transport. So the transport indication should stay same. However, a precaution should be same. In transport during incubator, isolation of the used equipment, use of personal protection tools and precautions. How we test the baby? Well, baby, no need to test for COVID-19 positive or COVID-19 suspected or positive mother, no need to test unless the baby is unwell. If the mom is well, then we can send we can send the baby home with other caregiver until the mother is negative. If the mother is unwell, then the baby should discharge home, and the same for separate caregiver or a relative. If the baby born to a mother COVID-19 suspected or confirmed, this baby should be considered infected until the test says otherwise. And even if the test said otherwise, there should be an incubation period or a guaranteed period of 14 days, and during that, the baby should be considered infected. If the baby is symptomatic, then the baby should be tested immediately. Now, should we breastfeeding? We don't know. We don't know if the virus can go through the breast milk. And if we consider other respiratory viruses and other COVID and coronaviruses, they should be destroyed by the pasteurization. However, direct breast milk, it cannot be allowed, not only because of breast milk, but also the mother is infectious. So it's wise to separate the baby from the mother until she is negative. If the mother can express her breast milk, should be a designated pump and designated area, and this milk should be pasteurized and then given to the baby. Despite we are not sure that a breast milk can contain virus, there is no evidence. However, a precautionary measure should be taken. Now, what we do for the baby? Clinical examination should be done within 24 hours, even if the baby is asymptomatic. Any baby, if asymptomatic, but he is COVID-19 confirmed or suspected mother, should be done. And the practice is to early discharge the baby as early as possible. Audiology screen can be postponed because this is not very emergent, and until the baby passes 14 days, and then we can give an appointment to do the testing. Now, there might be an emergent situations during this period in an ICU, and this can result of overadmission and isolation of COVID-19 suspected or confirmed mother, but also our staff, anybody who's in contamination or need to be guaranteed or get infected, the number will be decreasing, and there should be a plan, plan A and plan B, how we deal with the shortage of staff. It's always important to not exceed a huge number of gathering So the sign in, the sign out, the round should be limited numbers and should be away from the baby if possible. And the most important is to limit the number of people in that room. Now, of course, the mother who is infected not allowed to visit. If one parent infected, then the other parent will not allowed until they are tested negative. And a period of guaranteed of 14 days should be passed. Now, if they are not negative, it's better not to allow visit of other than the mother and father. Mother is free if she's not infected. Mother free and the baby is admitted for other reasons of other than the COVID-19 infection, allowed to enter anytime because she need to do breastfeeding. The father, however, can be limit their visit. Other visitors should be prevented from coming to the NICU to limit the number and the chance of transferring the infection to the patients or to the staff. However, exceptional circumstances sometimes need to think about and with a senior person and the infection control group in your hospital. We can use alternatives such as video meeting to avoid separation between parents, family, and the baby. However, any visitor should be checked. And the most important, there is a logbook or registry to check the temperature. Maybe they can sign a document that they never exposed or being in contact with a patient suspected or confirmed infection. So a logbook of timing and naming and registry of whatever happened to the visitors should be is a great tool, in addition to checking the temperature and the questioning the parent on entrance regarding their symptoms, if any. There is no need to self-isolate yourself after looking for suspected or confirmed infection if you are putting personal protection equipment correctly and safely and taking the precautionary measure to prevent drop and droplet borne infection. If you suspect or think that you've been in contact with a possible infected person, then discuss it with your senior staff. Please minimize the unnecessary contact and presence near bed or possible anything that makes you more contact with patients, such as patient round, sign in, sign out, documentation. Try to do these things that if you don't need to give medications or do examinations, direct contact with patient, then do other things away from the patient. If we need other services, example imaging, but it can be other subspecialties, cardiology. This need to be discussed with radiologists, for example, of imaging. If cardiology, then need to be discussed with cardiologists and so on, surgery and so on. The standard personal protection equipment should be on as the standard of practice and infection control policy. Cleaning and sterilization of equipment used between procedures, especially an equipment that's being used, such as X-ray machine or ultrasound, between patients should be cleaned and as per infection control policy. Always discuss these with senior staff. That sometimes can be deferred if not very urgent or is not absolutely needed. And these are my references. There are many, and also I use a little bit of my previous experience with the. Thank you very much for watching this, and if you have any question, please don't hesitate to ask. Thank you very much. I'm Yahya Ithawi, a consultant neonatologist.